So I'll just quickly just show the slides. This is what I talked about, the objectives, right? Then NHS I'm not going to talk about because I think everybody can hopefully knows something about the NHS, the National Health Service of the United Kingdom. Resilience is what I was talking about, and I was talking about the definition by the Royal College of Nursing, which is a very nice one. It's all about optimism, that you have a system that responds to the adverse situation and comes out stronger. And the same for the London Business School, the ability of an organization to anticipate, to prepare, to respond and to adapt to incremental changes and sudden disruptions in order to not only survive but prosper. And so, as I said, it's a holistic view of business health and success. Four key categories are important or central to supporting, maintaining, and developing organization resilience. And really, it's about leadership, having really good leaders in the organization, investing in your people, in their training, setting up processes that will work, that are reliable, that are relevant, transparent, and robust. And if you do all this, then the product that you will make or the care that you will give to your patient should be pretty good. So what do we do in the UK? Well, all emergency medicine physicians, if you're going through a training program, you have to go through this course called MIMMS. It's basically a very nice course run in Manchester, the Major Incident Medical Management and Support course. And they have a hospital version of it. And what's it about? It's basically explaining to you what major incidents is. So for instance, in this case, we have a health-related major incident is described as any occurrence presenting a serious threat to the health of a community. It is likely to involve disruption of services and require implementation of special arrangements by hospitals, by GPs, by mental health trusts, by ambulances, CCGs, and the Department of Health. And this is what we face. There are 4 phases to a major incident: the initial response, the consolidation phase, the recovery phase, and then restoration of normality. And I would say we are in stage 3 at the moment. Obviously, for managing major incidents, it means there needs to be a lot of planning, there needs to be a lot of training, a lot of practice drills, mock scenarios, managing incidents from hospital perspective. You may have to manage incidents from a pre-hospital perspective. And training, so this training on this program, on this MIMS course that we all go on, is basically not only lectures, but a lot of tabletop exercises, which I particularly love, and I use them in my department, skill stations, and then we go to different incident locations where, potential incidents can happen. We've gone to stadiums, big stadiums where a big sporting event might end up in a major incident. A possible terrorist attack might happen on train stations, on the tube. We've been to industrial zones. So it's a really good place to, do your mock exercise and be prepared for the real thing. And so they focus on 7 principles. And this is what we did. And this is how we always respond to any big mass casualty event or any crisis that happens. And we follow this mnemonic, CSCATTT. And it's basically, C stands for command and control, then safety is very important, communication lines are really important, the assessment processes need to be set up, triage, treatment, and transport. And I'm going to talk briefly about some of them. Another concept they talk about is collapsible hierarchy in disaster management. This is really important. So this is our A&E nurse, one of the A&E nurses who got really sick and she recovered, and the IT consultant is taking, she's going back home, and the IT consultant is taking her home. And what is collapsible hierarchy? It's basically a system that is used in major incidents to delegate staff. And they're put into 3 types of roles. You either get a medical role, nursing role, or management role. And it's providing core roles and responsibilities which have to be carried out throughout the incident. It's what it is, it's about skills rather than titles. So as Dr. Daniel Machini in Bergamo said, and it's a very nice thing he said, that there are no longer normal surgeons, there are no surgeons, no neurologists, no orthopedists. There are only doctors who have become suddenly a part of a single team to face the tsunami that has overwhelmed us. And this is what we did in my trust. So how do you do it? You go through the 7 principles. We have to set up command and control. And that these 3 things happen in the first few hours. As soon as we know a crisis is about to hit us, we set up command and control, we set up some safety processes, and the communication lines have to be set up very quickly. And what is command and control? So in the UK, in the emergency services of the United Kingdom, we follow the system of gold command, silver command, and bronze command. Gold Command is strategic, usually at the level of Department of Health and Clinical Commissioning Groups, the CCGs. Silver, which is tactical, refers to those who will be near the scene, and they will provide the overall management of the response to the emergency. And so in the case of our hospitals, it involved the chief executive, the chief operating officer, head of finance, head of nursing, and the medical director. They meet every day as part of Silver Command. The Bronze Command is operational, also called the Tactical Huddle Group, and this is where emergency medicine consultants come in. And what their remit is that during the current COVID pandemic, there is a need for improvement in cross-specialty team working. And this is really important, shared situational awareness. So what it means is that we meet twice a day, acute specialties, and those acute specialties are emergency medicine, acute medicine, anesthetics, ITU, operations team, pharmacy, infectious diseases, and states. These are really important, these guys who put up the signs, who close doors, who make sure people can't go from red zone to green zone. So so we all used to meet, not anymore twice, it is now like every day, but we still continue to meet to ensure that all potential issues and pinch points are recognized and made aware of. All the relevant specialties are informed, we mitigate them, and so patient care will improve. Second pillar, safety. And safety is, it's quite broad-based. And in this particular case, it was making the environment safe, safe for staff, safe for patients, looking at our PPE and what we had, and and the procedures, and whether people were trained to put it to the donning and the doffing, as we call it, and then also looking at procedures where we would put not only staff at risk but also patients at risk. We also had to make sure we were sustainable with our staffing rota, and then obviously the staff would need to be tested whether they had COVID or not. This, I would say, didn't work very well. It's still, now they're catching up, but it didn't matter. We just carried on with some common sense. When you look after safety, that's clearly linked to triage. And so we had to set up a green and red zone. The red zone was the COVID zone where all the potential COVID-19 patients would go into, and the green zone where it was non-COVID. 2 weeks later, we set up a respiratory assessment unit, and this was managed not by emergency medicine, but by pulmonology and cardiology. And they were seeing all the walking respiratory patients. And it was really a way of, taking the pressure off emergency medicine. All our minor injuries went to fracture clinics, so they were completely taken away from our, geographically from our area. And that also helped to release a lot of space for us and worked really well. And then finally, when you're talking about safety, then, you want patients to go not only into the right red zone or green zone, but you need everybody to know about it. And so we had ambulance services following protocols and taking patients to the right place. We also sent a lot of care home patients back. I think thousands were sent, and we know that there were not very good results of that, but that's another completely different talk. And so Public Health England gave us guidelines on where we use surgical masks, where we use FFP3, and clearly there's a good communication going on. The Royal College of Emergency Medicine came up with a safety flash about buddy systems, and it was early in the pandemic. Nobody really knew much about this virus. We had seen what was happening in China, which seemed quite chaotic, and did not seem, it seemed pretty panicky there. Then we saw Italy, it looked even worse. And so the next thing was hitting us. And so we had to, reassure our teams, we had to reassure young doctors. And so the buddy system was actually really good. Either doctor, senior doctor, junior doctor, or nurse doctor working together. So making sure you're donning and doffing your PPE properly, you're doing procedures together, just like deep sea divers working in a buddy system. Last but not least, I'm going to talk about communication. Communications are so important, communication lines. And communication failure is the most common pitfall in crisis management. This is where it's the make or break of your major incident policy and management. And so what we did was we quickly, technology really helped. So we set up WhatsApp groups. So the emergency medicine consultants had their WhatsApp group. We also had a general WhatsApp group for all the doctors and nurses. And so messages and, could be disseminated really quickly. The tactical huddle group was not only a command, Bronze Command Group. It was also a very good communication group. Royal College of Emergency Medicine set up Zoom seminars and conferences with us at least once a week. Early in the pandemic, it was twice a week, and then it became once a week. Our CEO gave daily briefs, and then the government was giving public health messages daily. This good communication actually led to very quickly we developed some trust guidelines. RChem, our Royal College, shared protocols from other hospitals, so we were able to see the protocols of other hospitals and make ours better. And all the other specialties, gave us no problems. They were just brilliant. And so that led to really good treatment protocols. Okay, so RChem is helping us. All College of Physicians had their protocols, which we quickly embraced. NICE was looking at, all the, because there was so much on the internet. And we didn't really, the evidence for that was, not sufficient. So it was good to have NICE with us, guiding us on what works and what doesn't. And the NHS is all about rationing. It's all about using your money carefully. So we don't like to waste too much money on fancy drugs which have no effect. So this is the tactical huddle group. And what will we talk in I've told you it was twice a day who was in it. What we discussed was activity in the past hours, 12 hours, what was anticipated in the following 12 hours, what were the staffing levels of medical and nursing and relevant others, i.e., is the pathology department going to collapse, or have their machines, not stop working, whatever. And then also anticipating issues like, the stores of PPE. Are they running out? And then finally, any interesting cases that we can learn from in the last 12 months. So this group was really, really key to making things work very well. And this is, us, group of us, looking at RChem, and they're actually showing us how to do ultrasound, chest ultrasound to diagnose COVID. Okay, so Royal College of Emergency Medicine did this. So these are some of the Zoom conferences we were having on a weekly basis. So please have a look at this. Look at what we discussed. Just a quick look at what's on the agenda.
Ask me 2 more minutes, please.
Okay, and so you can see it's very hands-on. It's very practical things that we discussed. Okay, things like oxygen supply housekeeping. How to keep our supplies of a hospital not running out. Where to use CPAP, how to keep the pressures of the system going. Very important and very simple but very important things for the day to be working. And so here you are. This was one of the first things that RChem sent us, and see binary triage is very quickly set up. So binary triage means red zone and green zone. The research council told us how to manage cardiac arrest. And so what we did was, because this was a patient coming in with cardiac arrest was potentially COVID, a high-risk patient, so we were very careful about PPE, and they gave us guidance on level 2 PPE and level 3 PPE. We just used glucose device. We did no manual compressions, and we used eye gels for securing the airway very quickly. This is again lots of stuff coming through RChem Zoom. So what did we do? We reconfigured our hospitals into red and green. We canceled all those lifts. We increased the ventilator beds. So by getting all those anesthetic machines from theater, we had loads of more ICU capacity. And this was really important. The lockdown had actually, everything was closed. And so the only people who were moving about the country were the key workers. And so our trust really, improved rest areas for the staff. Fresh food supplies were given to us to take home as well. And I think that really helped to improve the morale of the staff. And that's some of us, so a lot of fresh food coming in. A lot of people also brought food from restaurants and stuff. It was really to keep the morale up of the key workers. It was just brilliant. Challenges, I think everybody faces the same challenge. I won't go through that, but I think the one thing I'm really worried about is that a lot of sick non-COVID patients did not seek medical help with GPs or with A&E doctors. That's worrying. A lot of them died, and we need to think about what happened there. Overall, the 7 principles of managing major incidents worked really well. RChem, I just wanted to, because Taj Hassan, he's not here, but he gave me this, he told me to talk about it very quickly, I will. 3 major strategic initiatives were developed in the last 3 to 4 years by RChem. One was to increase the workforce in emergency departments. We are at the moment, we've increased the training numbers by 130%, which is going to run for the next 2-3 years. It's a 5-year strategy. It started in 2018. And we plan to double the emergency medicine consulting workforce by, make it double in the next 10 years. Also, we've developed this Empower program, which is all about how to keep our staff, their well-being, keeping them keeping retention and retainment, giving making them feel positive about their specialty, and then finally, this is really important, developing the emergency medicine leaders program to help trainees and consultants focus on how to lead. So please do have a look at the Outcome website. We've got some really good stuff there. I'm not going to go through this. All I'm going to say is the NHS emergency department response is good. All patients who needed treatment in hospitals got it. All patients who required ventilation received it. We refused nobody. ITU bed capacity was significantly raised. Staffing was really good. We cancelled annual leave, all leave of all patients, all doctors. Some people had to do double clinical shifts. Nobody complained. And for the last 4-5 months, they've done it. Communication lines are well maintained. One weekend we were running out of PPE, and the military stepped in, and the Nigerian hospitals helped out. We did a lot of training and simulation in this period, which really kept the morale of the staff high. And the NHS will learn and evolve. Thank you.
Thank you so much. Can you see my slides?
Yes, we can.
Okay,
exactly,
great.
We can see that.
Well, let me begin by thanking the APPS UK for the invitation, and I hope what I'm going to tell you and share with you is going to be useful to your audience. So I was asked to talk about the response at Hopkins. Johns Hopkins is a relatively old institution in the US terms. Of course, what you have in the UK is much more, has a lot more tradition than here in the US. The institution is known for many things, including a pretty significant contribution to what we do in emergency medicine, the development of defibrillation. This is where I work. This is a newer building, and this is a quick picture of our resuscitation room in the emergency department. So where I work and what I do is obviously very different from what I used to do in Pakistan with the resource base that I have. So Hopkins has so far managed 7,500 cases. About 7,000 of those were inpatients. And when I say Johns Hopkins, I mean the Johns Hopkins Health System, which has 5 hospitals. And early on, the system decided that the main Johns Hopkins hospital, the pictures you see here, will become the primary COVID hospital. So all the peripheral hospital, while they manage the patient, they were, the plan was and is to actually bring everybody to the central location where we have now a lot more experience in managing these patients. Now, all of you have seen, or I guess all of you have seen or heard about this, a dashboard that a few people at Johns Hopkins started very early on. And based on the numbers, of course, US is doing the worst. What we have done at the public health level is a great example of how not to do things. So, it's all about really leadership. You have examples of great leadership, and then you example of the worst leadership of its kind. And of course, the numbers show that. Now let me quickly get into how the emergency department at Hopkins, and generally I think all of us, have responded to COVID. The critical priorities for us early on was to be ready for caring for a large number of patients, also being able to manage critically ill patients, and finally keeping the staff safe and reducing their anxiety and fear so the system doesn't break down. And when we started talking about this at one point, we were very worried, and now I think things have worked out not as bad as we thought. And there are 6 priorities, 5 or 6 steps you can do to achieve those priorities. So changes in triage criteria and spaces, we heard about that a little bit in the last presentation. Testing, both availability and efficiency. How long does it take to get the test done? The emergency department design change, availability of and use of PPEs, clinical care guidelines, and finally, and very importantly, staff support and communication. So I'm going to just quickly go through what, how things changed for us when we were starting to do this, and it's actually still, we're pretty much in the middle of this crisis. So our triage, for example, moved from the single question we often ask is, how sick is the patient, to first, what is the COVID risk, and then how sick is the patient. We continue to have evolving case definition, and we used clear and broad risk stratification. And there was a time where every week we would change the definition because the epidemiology was changing. It was done at Hopkins, of course, through collaboration and learning from other places. For testing, we have now for the past few weeks stat testing in the ED, so I can get a COVID test in 45 minutes, an hour, and determine, you know, where the patient is going to go, how I'm going to manage it, and do I use my PPEs on those patients. Guidelines are available, but importantly, the treating physician has a final authority really on who to test and how worried you are. Do you need to do more testing than others? So it's a very decentralized system, and a lot of focus is on who the primary care or the emergency care provider is, and they will be the one determining the care. The ED design change, we essentially, as Dr. Yasmin mentioned before, two emergency departments essentially, different teams. Every resuscitation is considered a potential case, and I know many of our colleagues were struggling with negative pressure rooms. We learned when, you know, in the COVID that the whole emergency department was designed to be converted to a negative pressure emergency department. So it was we could change the whole areas of the ED at one point or separate points, and that was really helpful. So you can make one single room negative pressure, or you can make the whole emergency department negative pressure room. For the PPEs, there was a lot of, as you probably remember, globally hue and cry about PPEs. We were told that they're available and that we have plenty of them, but be careful because we don't know how long this will last. So even now, at the minimum, for patients that are non-COVID or non-PUI, everybody's wearing masks and eye shields. Then we have PAPR, N95, eye protection for other patients. Of course, gloves and gowns are available. So it didn't really become, where I work, become that big of an issue that you heard about other places. The other thing that was done is clinical care guidelines, very focused on evidence-based, regularly updated. It's part of of our electronic medical record. So I don't have to look for something else. I can go there and say, hey, you know, I didn't work for 5 days. Now I'm coming back. What are the changes? And it will show me, and I can actually directly order from those clinical practice guidelines things that I need to do. And they were developed and owned by my colleagues and ourselves. So there was not somebody else telling us. Of course, there was a lot of consultation between departments, but it was owned by the emergency department. And finally, it was very clear that there's a clinician leadership of the whole thing. There was a clear and honest communication. We were not told not to worry about. We were not told ghabrana nahi hai. We were told that, you know, things are going to be bad. Be ready. This is what we're going to be doing. We will take care of you if you get sick. There was no blame if you got exposed. There were mental health resources. People were using telemedicine much more. I'm just going to move to this other question of resilient health system, and I really like this diagram. It's from 2017, and what it does is it, you know, focuses on 4 areas of disaster reduction. Our focus, of course, is emergency health response, And how does this emergency health response affects these 6 pillars of healthcare system, including information, obviously availability of medicines, financing, leadership, healthcare delivery, and workforce. And what can you do within each one of these domains so that you have better emergency health response? I think if you really are thinking about creating resilient health system, this kind of approach would be very, very useful. In my last couple of slides, I'm going to share with you what I thought I learned as a practitioner of how good systems can function. One is the whole real focus on data and teamwork. I've sort of combined these two. This is our command center, which we use on a day-to-day basis. So Hopkins is extremely data-driven, and so is, I'm sure, NHS and others. And the system really goes where the data takes them and tries to minimize the personal biases. And this was, very early on. This was before we started wearing masks in the hospital. The command center was put together, and it was 24/7. It was right above the ED, and you could call in and you could get information. And when in our own emergency department, we had a sub-command center which would give information and make help available. So data, teamwork, and finally, learning and relearning systems. I thought that, many a times we would talk about doing something and the discussion would be, why don't we simulate it? Well, let's go into simulation lab. Let's try how this will work out. And let's observe what the good things, bad things are, and learn from it. And if things are not going well in the actual practice, let's try and change it. So the leadership was very quick to respond, and we were able to make quick changes. Now, having said that, not everything went very well. We I think, went from a very aggressive, for example, airway management early on to now a different kind of approach and many other things. But overall, I think that we have really learned a lot. While the country is still in trouble, I feel privileged to be part of an institution that is really willing to innovate, learn, and work as a team. Thank you so much.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Hope you can see my slides.
We can see that.
Yeah, we can see.
Yeah. Great. So I'll be talking about emergency department, Lady Reading Hospital. Just to give you a bit of background about the general perception of public sector hospitals in Pakistan. It's usually called a casualty or emergency room where anyone can walk in and can ask for the treatment. The presenting severity is defined by the patients and relatives themselves. There is no admission or discharge criteria in place, no concept of triaging, only filtration to the relevant specialty from casualty, and there is no concept of active resuscitation within the emergency department. And most of the medical staff don't know the concept of emergency medicine, that what is emergency medicine? If you are emergency medicine, then how can you treat people with trauma? So emergency department are used primarily in primary and secondary care. Mainly GP care is provided, and that's how public sector hospital emergency department as a whole works in Pakistan. What I've seen, I joined in 2017, and I've seen changes over the last few years. The first thing was that recognition of emergency medicine as specialty in major hospitals. Mindset change very slowly but surely, and tertiary care hospitals started to have trauma centers. Public actually has started to ask for emergency care provision or emergency medical provision care in ED. And the role of College of Physicians and Surgeons of Pakistan and Pakistan Society of Emergency Medicine. Now, Lady Reading Hospital is basically in Peshawar, and you can see it's very close by the border of Afghanistan. Actually, Jalalabad is closer than Islamabad to us. And this is where LRH is. LRH is right in the center of the old city, and it's quite a congested place. And the reason why I'm showing the slides, because that actually tells you about the amount of walk-in patient that we get within the emergency department. Just a snapshot of Lady Reading Hospital. It's a 2100-bedded tertiary care hospital, teaching hospital. It has got 27 different specialties. Most of them are recognized by CPSP for training. Daily outpatient on average is 4,000. Daily emergency registration average 2,200. It's the only trauma level 1 hospital in KP. First ever public sector hospital in Pakistan to start emergency medicine specialization. Emergency department itself, it's a 200-bedded ED with 390 staff working in emergency department. Lady Reading Hospital has a history. It has dealt with around about 304 militancy-related major incidences since 2007. So just a background of the hospital itself. Since 2017, we've established the services within the emergency department where any emergency department should have those services. And obviously we have to do it in a mega phase because of the numbers coming through. And that's why we have got the biggest trauma resuscitation bay is a 36-bedded, fully equipped trauma resuscitation bay. We've got a separate pediatric and gynae emergency department with a daily load of 900 patients. So, COVID-19 and Lady Reading Hospital emergency department, the question was that, and still is, that were we prepared? Were we equipped? Were we trained? Were we following strict infection control policies beforehand? And really, was everybody happy to be the part of the team in this crisis, especially when there's so many speculations and rumors going on. And I'll tell you, I'll correlate this rumor thing with my upcoming slides. And the biggest issue was that, PPEs, do we have enough PPEs and everything? And I had a responsibility being the director emergency. I was the one who has done MIMMS. I was part of having spent 15 years in UK and worked in emergency medicine and as a consultant and worked through MIMMS and stuff and HIMS. I took the responsibility to actually tell everyone that we need to be prepared. We need to act upon early. So we started doing things slowly and gradually beforehand. And so we started our preparedness. We started to have preparedness beforehand, that we had our first patient positive in Pakistan. We arranged PPEs, hazmat suits, N95 mask for ICU and emergency department. Very limited quantity to start with, but slowly and gradually it started to build up. Started working on setting up safe and unsafe zones within the hospital and emergency department. And the emergency department itself is huge. The triage is usually inside the emergency department and in the doorstep of the emergency department. But for this, we set up a mega triaging outside the emergency department, right in front of the gate, to help deflect the patients from one area to another area. Start to develop protocols, pathways, and trainings and donning and doffing, and vent trainings as well, ICU trainings. So Just a few slides that were, because we were trying to achieve like a big triage system, so we came up with like improvised kind of triaging. We set up like different stations. We would do different kind of role. We'll play a different kind of role, and this is the path that we follow to start with, and then slowly and gradually the case definitions start to change, and we start to play around with the triage tool. Now, within the emergency department, we set up safe and unsafe zone. To achieve that safe and unsafe zone, we created a huge screening area. So every patient who was symptomatic and needed to be in hospital, needed medical intervention or attention, they used to come to a particular area. It was a 40-bedded area where we have established a separate X-ray for imaging and a full blood count just for initial screening to see that, like, because the swab itself usually would take 24 hours, so it was difficult for us to separate like high risk and low risk patients. So that's the strategy that we achieved, and then we came up with a pathway that which patients are going to go to HDU and ICU. So we developed our own pathways, and this is the pathway that we used for our swabs, because you, in public sector hospital, you have to bound everyone that this is your job. Otherwise, if you're not letting them fit in that particular role, everything can go haywire. So we ended up having pathways for each and every step, and we delegated that job to those particular teams. This is the pathway that we had for patients presenting to emergency department, and after screening, who should be going straight to ICU, who should be going for NIV trials, and if they fail NIV, then to ICU beds. And obviously, just to let you know that, like, we had the biggest ICU setup in KP. We ended up having around 70 ICU beds and 280 high dependency beds that was created for this patient, because Lady Reading Hospital was nominated as the main intensive hospital, like intensive care hospital for KP. So our emphasis was more on really unwell patient rather than just walk in and quarantine or a home isolation patient. So 21st of March, we had our first patient presented, and since then we have seen lots of patients, out of which we ended up referring 550 to high dependency unit and directly referring 98 patients to intensive care. Then we had another hospital paired up with us for kind of oxygen therapy when the beds were the same, like HDU setup, and that was Police Hospital. So we ended up referring from emergency department 394 patients down there. Now this llama is basically left against medical advice. You can see the figure 212. They were all really poorly patients. And then if you look at the, as a whole, figures presenting to emergency department, like if you look at 1,553 patients, they're quite low considering Lady Reading Hospital. So there were rumors and speculations that whoever is going to go to hospital is going to get an injection, and they will end up having the medical staff deliberately want to kill them, the patients. And that's why the people were reluctant, firstly, to come to the hospital. And secondly, even if they were sick, they didn't want to stay into the hospital. And these speculations in the room, as Dr. Yasmin said, that like the poorly patients were not coming to the hospital. So the death ratio reflects as well that they didn't utilize the resources that the community should have or could have. To tell you what, it was not all COVID. We ended up having 115,000 patients since 21st of March till the end of last month. And I can share the figures from just our ED trauma resuscitation room. In this particular time, we ended up having 8,959 major trauma calls. That included RTAs, firearms, stabbings, and history of falls and stuff like that. You can see the figures. So many patients came in, admissions that you can see, and also we have got like 6 major operative theaters, and you can see the cases from the neurosurgery, 390 major surgical cases, almost 2,000, and orthopedic cases of almost 400. What we gained from COVID, as a public sector hospital, we have got now improved infection control strategies. We work more like a team now because we ended up having MDTs daily. We discussed about things. We developed like links with US, and the US team used to and still doing like ICU round on Zoom and on COWS, improved communication in between. We ended up having PRT, our primary response team, on the COVID complex, and the consultant-to-consultant referral pathways, new pathways with implementations, because it was not just creating pathways, we actually implemented them, and we have got preparedness strategies now. What I'm glad about, that all the staff, medical staff, started to talk about like the same language of resuscitation, like non-rebreathe mask, like a high-flow oxygen, and talk about like saturations and SATs, and when should the patient be referred to HDU, ICU, and the changes in the CPR and stuff like that. We ended up having airway teams, transfer teams, and I'm so glad to see the resilience that like the Relearning Hospital shown, and the self-belief. Though we had our ups and downs, though we ended up having our own staff of 421 who was positive for COVID-19, but alhamdulillah, all of them recovered and no casualty in the staff. So what's next? Now the biggest task is to open the outpatient. So again, 4,000 people coming in. How are we going to do that with SOPs? So for that, we ended up starting to establish filtration clinics, which is almost complete. So we're going to have a huge filtration area, and specialist referral to outpatient department. COVID-19 is still going on. We're still receiving patients. I'm not sure about like the second wave, or if there is any, then when it's going to be. So again, we're going to be going to square one. We want to go back to the normality, but like it can hit us again. And in the coming month, we're going to have Huddle, and we usually are very much prepared. Our major incident plan is activated in these 10 days, because it can be days where insurgency can happen, so we have to be prepared. So we prepare our mass casualty plan as well. And the struggle of the LRH emergency department continues. Thank you very much.
Thank you very much, Dr. Hamish Azad. It was